fractures. But the most commonly used are tile classification as well as Young and Berger. So we have a look at the tile classification first. Basically, it shows the stability of the fracture, the grading of the fracture based on its stability, and it will prognosticate the patient's type of fracture. So if you were to see the tile A and tile B, you can see that the posterior sacroiliac joint is actually still intact for both tile A and tile B. But in tile C, there is disruption of the posterior sacroiliac joint ligaments. So when these ligaments are involved, it means there is vertical and rotational instability, and this is a completely unstable fracture. Similarly, another classification that is commonly used is Young and Berger's classification. This classification uses the mechanical force to categorize the fractures. There is lateral compression, AP compression, as well as vertical shear. So again, the stability of the fracture depends on the degree of vertical and rotational stability. So there are few radiological investigations available to examine the mechanical force. The first line of imaging is pelvic radiograph. Is basically to assess for any pelvic fractures and lines. And then there is ultrasound. You can use ultrasound, which is easily available in the emergency department to assess for free fluid, as well as to look at the solid organ injuries. And then we have CT pelvis to look at the fracture configuration in detail, and it aids in surgical decision-making. And it is also good to assess for other associated injuries involving the pelvic organs as well as the blood vessels. And we have MRI, but it's rarely performed and is usually for occult fracture, and is good in providing additional information on ligamentous injury. And lastly, we do have angiography with embolization for cases with arterial injury in hemodynamically unstable patient. So if we were to look at the pelvic radiograph first, there are a few lines that is seen here. So these lines are used in pelvic X-ray to help us to assess for fracture. So the first line in red is called the iliopectineal line. So basically it's the continuation of the superior pubic ramus. And then we have the ilioischial line in green, which is the superior continuation, is the continuation of the superior margin of the inferior pubic ramus. And then we have the acetabular roof. We have the anterior acetabular wall, which is formed by the inferior margin of the superior pubic rami to the upper outer margin of the acetabular roof. And we have the posterior acetabular wall, which is formed by the inferior margin of the inferior pubic ramus to the upper outer margin of the acetabular roof. And then we have the Shanter's line, which will form a continuous arc from the femoral neck to the lateral and superior margin of the obturator foramen. So if you see disruption of this arc, it signifies there is a fracture of the femoral neck. And then we have the sacral arcuate line in yellow at the roof of the sacral canal. Any disruption indicates fracture of the sacral bone involving the sacral foraminus. So do use these lines to assess for pelvic fractures because it will help to diagnose any small fractures, especially minimally displaced fracture. So in this patient that was presented earlier, so this is the X-ray of the patient. The most striking features that you can see is that there is widening of the pubic symphysis. So when there's widening of the pubic symphysis more than 10 millimeter is called pubic diastasis. And when there is pubic diastasis, you have to examine and look for the sacroiliac joint, because if there is widening of the sacroiliac joint, it indicates there is an open book fracture. So let's have a look at the right sacroiliac joint. So the right sacroiliac joint is slightly obscured by the presence of spleen here. Okay. but it doesn't look widened. And if you look at the left sacroiliac joint, okay, the image is slightly rotated, but it's still intact as well. There's no obvious widening of the joint. But what you see is that there is a comminuted fracture involving the left iliac bone. So again, pubic symphysis, generally it measures about 6 mm, and it gets thinner at the age of 50. It measures about 3 mm. It's thicker in childbearing age woman, and in pregnancy it will increase up to 2 to 3 mm with the presence of hormones. So when there is measurement of more than 10 millimeter, it's taken as pubic diastasis. And again, you have to assess for sacroiliac joints when you see a pubic diastasis. So moving on to the patient CT abdomen and pelvis. So this is an axial view of the lower abdomen and pelvis in soft tissue window. Okay, first of all, you can see that the aorta as well as the IVC is small in caliber, indicating that the patient is actually under volume. Okay, there's presence of hematoma at the left paracollicutor. It's comminuted fracture of the left iliac bone with associated swelling of the iliacus muscle as well as the gluteus muscle. So this indicates intramuscular hematoma. There's also fracture at the lower left sacrum. Hematoma is also noted at the left anterior abdominal wall as well as the pre-vesical space. Okay, at the region of the perineum, you see these air pockets at the left perineal region, which is better depicted on the lung window, as well as at the gluteal cleft. So with this presence of air pockets at the perineal region, can't really rule out an anal tear. So this is a bone setting in axial view of the same patient. Again, we see the comminuted fracture of the left iliac bone, which extend to the anterior part of the left sacroiliac joint. However, you can see if you compare the right and the left sacroiliac joint, it doesn't look widened. Okay. Again, the fracture of the left iliac bone. And if you assess the posterior iliac bone, there is no posterior displacement of the iliac bone to suggest posterior sacroiliac joint tear. And then the fracture of the lower left sacrum. Again, this is a pubic diastasis and the fracture of the mid-shaft femur that was seen in the radiograph presented earlier. This is the coronal view. So again, you see the pubic diastasis, comminuted fracture of the left iliac bone extending to the sacroiliac joint with no widening of the sacroiliac joint, and fractures of the lower sacrum. Okay, so when we do a CT pelvis in a trauma case, we will usually provide with 3D recon of the bone to assist the surgeon for surgical planning. So if you can see here, the fractures is well shown here, comminuted fracture of the left iliac bone, and you can see that the sacroiliac joint is actually quite intact, and the pubic diastasis. This is another view. So in our case, in our patient, okay, there is pubic diastasis. So most likely is an AP compression mechanical force, but there is no disruption of the posterior sacroiliac joint with the sacroiliac joint still intact. So it's most likely an AP type 2, a partially unstable fracture. So this is a pubic diastasis with comminuted fracture of the left iliac bone, extending minimally to the left sacroiliac joint, no sacroiliac joint disruption. There's multiple air pockets in the perineal and gluteal region, gluteal cleft, raising the suspicion of injury to the perineal structures. So important to note that the pelvis is a ring-like structure When there's significant disruption and displacement in one area, it must be accompanied by a second disruption in another area. Thus, most pelvic ring injuries include fractures or dislocations of both the anterior and posterior structures. So in general, when there is fractures and dislocation with displacement of more than 1 centimeter, and injuries that compromise the posterior sacroiliac ligaments, they are often unstable and warrant close attention at initial evaluation. However, the placement of pelvic binder or sheet may reduce the deformity, making it difficult to detect at imaging, especially in the absence of fracture. With that, I thank you.
Okay, thank you, Dr. Emilia, for sharing it in regard to the radiological findings and the interpretation. So, as to recap, as for now, our working diagnosis based on the clinical and as well as the radiological finding, patient is having hypovolemic shock secondary to the open pelvic book fractures and multiple low bone fractures. So with that, I think the initial management is very important and paramount in order to us manage patient further. So with that, I would like to invite Dr. Syed Muhammad Shafiq, trauma surgeon from the Advanced Musculoskeletal Unit, to discuss about the initial management.
Okay. Thank you, Kamarul. Assalamualaikum and very good. I'm Syed Muhammad Shafiq from the Advanced Trauma Unit department in UKM. So before we dwell into the definitive management or what was done to the patient, I will talk about the initial management in polytrauma in general. Okay, this is the outline of my presentation, definition, epidemiology, management, and we will touch upon regarding the definitive care or when to go in for surgery, when to fix. So I will touch upon early total care, damage control orthopedics, and early appropriate care. So the definition of polytrauma is a clinical state following injury to the body leading to profound physio-metabolic changes involving more than one system. So that is the key word, it involves more than one system. For example, an unstable pelvis fracture with associated... Can you see my... sorry. I'll try to share again. Can you see my slides? Is it moving? It's moving. Okay.
Like view, okay?
Is it moving?
Moving.
Moving, eh?
Okay.
So it's moving, is it? Moving. Okay, all right. So the definition. So for example, unstable pelvis fracture with associated visceral injury as in our patient. So if you talk about polyfracture, which actually multiple fractures involving only one system, so the musculoskeletal system. So this is the definition. So moving on to epidemiology. So this is based on the WHO road safety report. So polytrauma cases is the 8th leading cause of death for all age groups. is actually ranked first among young people and projected to be the third cause of disability in 2030, which is significant. So if you look at this slide, this is the trimodal of death. So it actually describes the distribution of trauma death based on time. So if you look, about 80%, this yellow box, what we call the golden hour, occurs in the first hour of injury. So rapid trauma care actually has greatest impact for this patient. The earlier you get them to seek medical attention, the greater the impact would be. Okay, so what is the aim of our initial management? Is actually to restore the patient back to his pre-injury status. This is to prevent mortality actually by disrupting the triad of death. So the triad of death actually involves coagulopathy, metabolic acidosis, and hypothermia. So resuscitation is aimed to disrupt this vicious cycle and always prioritize life over limb. So our management in resuscitation is actually based on the ATLS, which remains the core management. It has been revised, I think, 10 times to the latest edition of the 10th edition. But these four main stages remain the same actually. So which is the rapid primary survey with simultaneous resuscitation, detailed secondary survey, constant re-evaluation and initiation of the definitive care. So despite being revised 10 times, these four stages remains key and is always there. Okay, so going to the primary survey, first airway with cervical spine control, breathing and ventilation, circulation where we control the external bleed and resuscitate, dysfunction, check for your central nervous system, and exposure. And we also have adjunct things such as the trauma stress imaging and ECG. Bear in mind, during this, life-threatening conditions are identified and the management is actually instituted simultaneously. So in resuscitation, the goal is to control bleeding, replenish and replace with resuscitation and constant evaluation. Control bleeding can be as simple as compressive bandages, pelvic binders, pharmacological agents such as tranexamic acid, and surgery if need be. Replenish and replace. So the resuscitation guideline has evolved. Current guideline is moving towards blood products. And then we evaluate, and everything again is done simultaneously. And then we go to our secondary survey, which is your head to toe evaluation. Do a complete neurological examination, take a history if possible. The mnemonic is ample. Allergies, medication, past illness, last meal, and events or environment related to the trauma. And then additional imaging as needed, for example, CTs, and then we formulate a definitive plan. Okay, so when to fix? Okay, so after resuscitation, constant evaluation, so now is the time to decide when to go in for surgery. So the management has actually evolved with time. There are actually three concepts. The first one being early total care, and then it was revised or proposed another concept, damage control orthopedics, and then it was refined again by a term called early appropriate care. So moving to early total care, this is the mainstay treatment in the 80s and 90s. The concept of doing definitive fixation of long bones as soon as possible, because at that time it was thought that the term too sick not to operate. And then this was actually made popular because of the progressive improvement in osteosynthesis. So everyone was eager to fix everything in one shot because they thought that this would reduce the length of stay in the hospital, and everything can be done in one setting. Okay, the problem is that it led to exacerbation of the psychiatric phenomenon, which led to increased mortality. So patients were sent into ICU, and our anesthetic colleague were, managing them together with us, and we noted that mortality actually increased despite the fractures being stabilized and fixated on. So this is because of the second hit phenomenon. So if you look at this graph, actually this is what happens when we have a trauma. This is the normal immune system. So when you have a trauma, your first hit, this will evoke your SIRS, which is your systemic inflammatory response syndrome. So this is a normal immune response. So cytokines will be released to counteract this trauma. And then we have another thing which is intended to compensate the SIRS, which is your compensatory anti-inflammatory response syndrome. So this will be evoked, and it will go along in tandem with your SIRS. Okay. So when you have a second hit, meaning you go in for surgery, so your SIRS is still in a state of increasing in trend. So it does not have time to reduce because your CARS is actually overwhelmed. So this will cause another spike in your SIRS and will cause early MODS, which is your multi-organ dysfunction syndrome. Okay, so after a while, they came out with the term damage control orthopedics. So this was actually popularized in 2000. So DCO was actually coined by the naval army actually, which is a concept to patch up anything which is necessary for them to get to shore to fix the engine, for example. So actually everything is delayed until the physiology has improved. So the concept changed from to patients too sick to operate. So what are the guidelines, or which patient do we choose? So there are some parameters which can guide us to decide. The first one is your ISS, your injury severity score, and your AIS. So if you look at the chart again, if you study the chart, okay, the SIRS actually would reduce on day 5 to day 10. So this is your window period for your definitive treatment. So during the first trauma, what we can do, the most simplest thing is to stabilize the fracture via, if possible, using an external fixator or any temporary stabilization device. Okay, and then we wait until day 5 to day 10 within this window period to formulate or plan or to do our definitive fixation. Okay, so and then in 2013, they refined this guideline or this concept, because they still think that not all patient needs to undergo this route of DCO. Okay, so because of our adequate and very good resuscitation guidelines, which has improved over time, so the decision to operate is guided by laboratory parameters. So namely these 3 parameters, which is lactate less than 4, pH more than 7.25, and base excess more than -5.5. So if these parameters are met, okay, after adequate resuscitation, actually the time of surgery can be lessened. Okay, so the goal is to definitely treat the fractures within 36 hours, which actually can reduce the length of stay of the hospital, and the patient can do their rehab and earlier in time. Okay, so after this, Mr. Faiz will discuss regarding what was done to our patient, what route did we undertook, and by that, I thank you.
Okay, Assalamualaikum and good morning everyone. I will continue this case discussion. On my part, I will discuss about the fracture stabilization in polytrauma. Okay, so as far as the presentation has gone, we have the diagnosis of this patient and the current problem for the orthopedic side was involving the pelvic, which is symphysis pubis diastasis and comminuted fracture of the left iliac wing. He also has a closed midshaft right femur fracture and on an open midshaft right tibia fracture. Okay, so looking at this, there are multiple fractures which we need to see as a whole and also address individually. So for the pelvis fracture, the issue that can be arise is whether this is the cause of this contributes to the cause of hemorrhage, the fracture itself, whether it is a stable or unstable fracture, and also we already need to be thinking about the fixation, whether it's in the emergency setting, whether we should fix it temporary or even definitive. And regarding the long bone fracture, which is the femur and also the tibia, the issues that can be arise would be fat embolism, floating knee as it involves a ipsilateral limb of the femur and also the tibia. There can be complications such as vascular injury, and it can also contribute to hemorrhage. And with all this, we need to be thinking about the fixation, whether it is definitive or temporary. So as has been mentioned by Dr. Emilia, there are many ways of classification of the pelvic injury, which the most famous are the Tile classification and also the Young and Burgess classification. The bit of difference between the two is the Tile classification is based on the pelvic stability and is helpful and for guiding pelvic reconstruction. And in this instance, we have concluded, or we have analyzed the CT scan, thinking that we would categorize it being an unstable fracture within the classification of a Tile B3. And for the Young and Burgess classification, it is basically based on mechanism and injury and also indicates the stability, which we think is a APC type 2, which is and also considered as a unstable fracture. Okay, so in an unstable pelvis, as mentioned by Dr. Said, it needs to be managed from the start, which is from the ED setting itself. During that time, it is very important. It is also done simultaneously with together with the resuscitation. Things that can be done in the ED setting is a pelvic binder, which this helps to tamponate for a tamponate effect if there is any such bleeding inside the intra-pelvis. And also there can be a skeletal traction in a situation of a vertical shear, and also external fixator can even be, in certain circumstances, can be done in the ED setting. And after resuscitation, the patient will be assessed again and determine whether he can be brought to OT according to his condition, and what fixations are available to be done for him. So it can be either in terms of external fixator, a C-clamp, which is usually done for posterior pelvic ring injury, which I will mention later, and either even an open reduction and internal fixation. So these are the examples of the fixation or stabilization that can be done. This is among the example. The top two is an example of a pelvic binder, which is just applied externally, giving forces to the pelvis, stabilizing it to give the tamponade effect. And subsequently, Another option is the external fixator. This is the external fixator. The bottom two pictures are showing the external fixator of the pelvis. And this is an example of a C-clamp application, which is meant for a posterior ring injury. So when we talk about pelvic ring injury, for this patient, it involves both anterior ring fixation and also posterior ring fixation, as we have seen by Dr. Emilia, showing that there is disruption or diastasis of the symphysis pubis and also a comminuted fracture of the iliac wing. So there are a few options in how to fix these injuries. This is basically a definitive fixation. So for the anterior ring, there is option of a plate fixation or intermediate fixation if it involves the ramus. For the posterior ring fixation, it can be done percutaneously via a screw, and also a plate fixation, which is done via an anterior or even a posterior approach. So this is an example of the fixation, of a definitive fixation of the pelvic ring injury. This is the anterior ring injury, which there is on the top and on the left side is the symphysis pubis plating, and on the right side showing fracture of the ramus. And this is for the stabilization of using a plate and screws of the posterior ring. So coming back to this patient also has long bone fractures, which involves the femur and also the tibia. And in the ED setting, what can be done is, as we have done initially, was splinting of the fracture. They can also apply a skin or skeletal traction, and eventually the fixation must be decided whether we want to put in external fixation, plating, or even intramedullary nail. So for this patient, after resuscitation, he in ED ends up temporary stabilization. Patient was considered to be hemodynamically stable into operation theatre, saying we did a plating of the symphysis pubis, the plating of the iliac wing, and also external fixation of the right tibia. During this time, we also needed to consider that we need to give time for the surgical team to go in for exploration and exploration of the perineum region. So we did not continue to do all the fractures at once, just doing the most important part, such as Dr. Said has mentioned, what were in early appropriate care, among the fractures that should be stabilized if the patient was in a stable condition was involving among the long bone and also the pelvis. So we straight away did the pelvis to allow immediate stabilization of the pelvis, and we did external fixation of the right tibia, and we would track that lower limb to stabilize the right lower limb. Subsequently, post-operative, patient was remain stable, and after the second day, we went in again to convert the external fixation of the right tibia to interlocking nail of the right tibia and also the right femur. So this was what was done for the patient. There is a plating of the symphysis pubis, which you can see there that the diastasis of the symphysis pubis has been reduced, and also the stabilization of the iliac wing comminuted fracture involving using a plate and also a screw fixation. And for the long bone fracture, there's an interlocking nail of the right femur and also the right tibia via a approach through the knee to address both fractures of the femur and also the tibia. So thank you. And now I will invite Dr. Fardi from our surgical department to share regarding the management from the surgical side regarding the perineum injury.
Assalamualaikum and very good morning. Can you hear me?
Boleh Doktor, boleh proceed.
My name is Ahmad Fadi Sulaiman, a fellow colorectal surgery. Before I start my presentation, I would like to thanks to the organizing committee and orthopedic department because of inviting me for today's session. This is my disclaimer. All picture and videos taken with the consent from the patient for the research and education purpose. Okay. Being given task for the perineal injury, this is the actual picture of this patient that we are going to talk about today. This is my outline of my presentation. So the definition of the perineal injury, sphincter injury, is a tear and damage to the muscle that surround the anal canal, which is consists of internal sphincter and also external sphincter muscles. And the traumatic injury can be isolated either or with the low energy involving only the anal sphincter, or alternatively high impact energy with polytrauma. And but not least, the traumatic sphincter injury also happen in obstetric, mainly in the obstetric sphincter injuries. Before I talk further, we have to understand that surgery is all about anatomy. Okay, that I would like to share is the anatomy of the anal canal. So, what are the structures that are potentially involved in the sphincter injury? So, as I highlight here, there are two main sphincter, as I said, either internal sphincter and also external sphincter. So for the internal sphincter is an involuntary muscle that continue from the circular muscles that responsible for about 80% of the resting tone. Whereas for the external sphincter, it consists of deep, superficial, and subcutaneous. And the external sphincter is voluntary muscles that contract and maintain the continence, either the fecal, solid, or fluid. And when there is excessive diversion of the external sphincter, it can lead to the fecal incontinence. But for the external sphincter, it only maintains about 15% of the resting anal tone. For example, in the subcutaneous internal and external anal sphincter, is a fiber curve from the medially, whereas for the deep part, is a blind from the internal sphincter and also the levator anal muscles. Okay. Next is the structure that we need to know about the anogenital striated muscles, and it's very important because we need to know the degree of the injury and also how we're going to do the repair. Okay, this is the upper level of the anal canal from the levator ani, and the middle level mid anal canal from the anal-coccygeal ligament, superficial external sphincter, superficial transverse perineal and perineal membrane, and last but not least, the subcutaneous external sphincter. With this three-level concept for anogenital striated muscles, we need to know, because when we know about all this anatomy of the perineum, we need to know the degree of the injury, and either we need to do the immediate repair for the patient. Okay, this is a cadaver dissection that I'm going to share. It's given by one of my fellow colorectal consultant, Mr. Huzairi, while he was in Chulalongkorn Hospital in Bangkok. So with this, you can see here there is three-level concept for anal muscles. from the level ulna, you can see here superficial external and subcutaneous external sphincter. And last but not least, the levator ulnar muscle, the combination of group of muscle from the bulbar cavernous, puborectalis, and others. Okay, we go to the pathogenesis and epidemiology. Mainly the traumatic sphincter injury, as I said earlier, majority more than 60 to 65% due to the obstetric injury, whereas what we are going to talk about today is the accidental, carry about 23%, and iatrogenic. For accidental sphincter injury, mainly due to the accident, either involve single or multiple lesion, possible involvement of the rectum or any other organ structures. Treatment mainly in emergency setting or can be done later, and we need to consider stoma in the certain patient. Whereas for iatrogenic sphincter injury, it more involved to the internal anal sphincter compared to the external anal sphincter. And it's mainly due to the proctological surgery. For example, when we are dealing with hemorrhoid, fistula or abscess, fissure, when we are talking about the sphincterotomy, rectoceles, anal dilatation or rectal tumor, and also due to the anal instrumentation, for example, the insertion of the stapler. For obstetric and anal sphincter injury, OASIS, the prevalence is largely variable between countries and unit, and OASIS mainly happen about 3 to 4% in vaginal delivery, either they do the midline episiotomy, mediolateral episiotomy, and instrumental. And the sphincter injury, you need to know the classification by the Sultan classification. That I need to highlight is the 3rd degree and 4th degree. When there is a 3A less than 50% of the external sphincter, 3B more than 50% of the thickness of the external sphincter, and 3C when they involve the internal sphincter. But 4 degree when there is a disruption of the anal epithelium as well. What happened to this patient. Okay, and investigation that may available in the certain center, we are now in HUKM, SCTM, we do the endo and ultrasound assessment. Immediate means during the examination anesthesia, following that after the repair, 6 weeks and 6 months following the repair. Okay, this is a diagram of the endo and ultrasound from the upper anal canal. You can see here level 1. Following that, the mid anal canal, level 2, you can see external and internal sphincter, and the level 3 of the lower anal canal. And then the treatment option of the sphincter injury, you can do either overlap or end-to-end anastomosis, and approach either transanal, transvaginal, perineal, and abdominal. And we need to know what is our aim for the surgical treatment, mainly to restore the anatomy, which is the most reliable, to improve the anorectal function and physiology, just to avoid any sequelae of the complication, for example, incontinence, and also to avoid post-operative morbidity.
Attendance tak ada.
In the repair of the sphincter injury, we need to address the sphincter defect, recreate the perineal body, and plus minus we need to identify its possibility of fistula in certain case. There is overlap and end-to-end repair, and the reconstruction of the perineal body by means of the repair of cavernous muscle, repair transverse perineal, and also repair the external anal sphincter muscles. And there is an alternative or adjuvant approach when we are dealing with a delay detection of the sphincter injury by means of, or we want to get a good outcome after the repair. For example, we do the rehabilitation biofeedback, injectable bulky agent, gatekeeper or shin keeper, when there is an alternative, when there is less than 90 degree of sphincter lesion, and dynamic graciloplasty plus minus with the creation of the stoma. So I want to share the video about the procedure of sphincter repair on this patient. Okay, we can see here there is injury at the 12 o'clock, and then the first step is we need to identify, classify, and grade of the sphincter injury. So after the identification and extension of injury, we need to identify all the structure, which is anal mucosa, internal anal sphincter, and also external anal sphincter. Okay, following that, we need to control the contamination and hemostasis and start to do the repair of the anal mucosa. Better to remember that the important things while dealing with the repair, we need to make sure that the repair itself must be watertight, interrupted repair, and use the absorbable suture. I skip a bit. Okay. You can see here there is I'm using the absorbable interrupted suture with the intention to have the watertight and airtight repair. And then make sure not to catch the posterior part of the anal mucosa, because as I said earlier, the injury is at the 12 o'clock. There is a complete repair of the anal mucosa, the first layer, and then next is I need to after the identification of the internal anal sphincter, I need to do the lateral mobilization to get a good tension-free repair, approximation of the internal anal sphincter, either overlap or non-overlap repair, and then the complete repair of the internal anal sphincter, and then following that, the identification of the external sphincter plus the lateral mobilization of the external sphincter, and there is a complete repair of the external anal sphincter. Okay, and next is I need to recreate the perineal body just to have a good outcome of the patient. And following that, the subcutaneous and skin closure of the perineal injury. Okay, this is a complete repair for this patient and creation of a diversion stoma. And this is opening of the colostomy. And as I said at the second slide, is the outcome, the result of the repair. And after the surgery, we did the endo and ultrasound assessment. This is external anal sphincter, this is internal anal sphincter, this is anal mucosa, and you can see here this post-repair area at the 12 o'clock. So you can see here the complete circumference of the internal anal sphincter. Okay, summary and take-home message. Best effort in early identification and classification is very important. Repair should be done as soon as possible or can be done much later in the certain patient. Outcome of lead repair can be suboptimal. Alternative options are possible. Appropriate surgical technique and surgical training is very fundamental and very important. And stoma we need to consider and it based on the patient. And with my acknowledgement and thank you.
Okay, thank you, Mr. Fardi, for the presentation. So in view of we short of time, so maybe if any participant have any question, they can put in the chat box. Maybe we can entertain just one or two questions. So to conclude, for this patient, he was discharged well. I think just few days after post-op without any immediate complication. There's no sign infection. So to conclude, in the polytrauma cases, I think the multidisciplinary approach and the early intervention by each team is paramount to give a good result for the patient. So fortunate enough for this patient, we have our emergency department colleague which provide the adequate resuscitation and which able the patient hemostatically or physiologically stable enough to undergo the initial surgery, I think within 6 hours, the initial stabilization of pelvis and as well as the diverting stoma and the perineal repair by the surgical team. So the surgical team also take a big role in this patient in view of, as mentioned earlier by Datuk Sham, that open book fracture patient usually have a high mortality and morbidity rate lah. But in view of early intervention by various teams, so this patient alhamdulillah survived and discharged well lah. So as for now, I don't see any question from the chat box. Dr. Isham, any additional input you want to?
Yeah, thank you for the presentation. I actually want to congratulate everyone for saving this patient's life. I also appreciate very much the effort made by our surgical colleague, Mr. Ahmad Fardi, in this patient. From my previous experience, if this patient is diagnosed late, and especially when you are in a district hospital, so you have to alert the surgical team early if you want to successfully manage this patient. Another point that I would like to bring in is when you are in the district hospital, as all our students will actually go to district hospitals, right? A lot of times you don't have the facility of simple things, even like a pelvic binder. And sometimes nowadays it is the government policy that all our district hospital will have a general surgeon and also an orthopedic surgeon. But sometimes when these orthopedic surgeon are on leave, or when the general surgeon on leave, you need to refer the patient out early. And if you do not have the facility to have a pelvic binder, what you can do as a primary doctor in the emergency setting is you can simply use your bed sheet to use as a binder in all these cases. When you are in a small district hospital, the first thing that you need to do in this patient after you make the diagnosis is you need to restore the length of the leg, tie the leg together, and then you can use the your hospital bed sheet and tie around the pelvic area, and this will reduce the pelvic volume and create a tamponade effect also. So again, you have to cooperate very well with your general surgery team to successfully manage this patient. Thank you.
Thank you Dr. Isham for the input. So Encik Bukhari, lepas ni Kahoot session ke untuk student?
Betul.
Okay, right. So for I think thank you for all the discussion and speakers to join us today. So I think for today's session for the presentation, I think that's the end of the presentation. So next is just for the undergrad student lah, for the Kahoot. So, boleh paparkan Kahoot soalan ni kot Encik Bukhari.
Okey, sekejap. Hilang pula. Betul. Okey, selepas saya pancarkan barcode ni, saya akan pilih Kahoot. Ini adalah CPD point punya barcode. Tolong gunakan MMA apps untuk doktor saja. Untuk semua partisipan, sila isikan link yang saya telah share di ruangan chat. Terima kasih. Undergraduate yang masuk kahut ini, tolong gunakan nombor metrik. Terima kasih.